How is it that the wealthiest country in the world has such a screwed up healthcare system? After 35 years in the healthcare industry, I decided to retire and share my secrets with you. I'm Chuck Melindy, and this is Disruptive Dialogue. Hey everybody, Chuck Melindy with Disruptive Dialogue. We are in the second episode of Healthcare 101. We're talking about private insurance. So last week, we basically did an overview of private health insurance in the US. And basically, it was a basic course on premiums and deductibles and that type of thing. This week, what we're going to talk about is the second episode, and it's going to focus on barriers to access and care and how you can overcome those. But before we go there, I just want to do a quick review of the last episode. So a couple of things. Remember, health insurance, as y'all know, can be confusing when comparing plans and understanding eligibility. The cost of your insurance is going to vary, and that's going to vary on a number of factors, but they usually, your costs are going to include your premiums, which are your monthly payments, whether you pay for that care or not, your deductible, which is the out-of-pocket costs on top of your premiums that you pay before the insurer starts to pay anything, and then copays and coinsurance. So that's in addition to your premiums and your deductibles. Once the insurer starts to pay for part of your products and services that you consume in healthcare, you will still own a portion of that payment, and that'll come in the form of a copay or coinsurance. I did make comparisons last week. One comparison was like deductibles are kind of like a deposit when you go to an apartment. Just like you pay a monthly lease at your apartment, you pay a monthly premium in health insurance. I mentioned that deductibles are kind of like your deposit because at the end of the day, you're going to give them money and it can go up if you want certain things like have a cat or, special things, just like you would with a deductible. But the difference is you get your deposit back at the end of your lease. You don't get the deductible back. I just wanted to clarify that. So we also see that private insurance is usually employer-sponsored, large or small group plans, and then there's the ACA marketplace, and those are for individuals that are not enrolling through their employers. One thing that we touched on was that the enrollment periods are near the end of the year, that we need to become better consumers of healthcare to make it work. I mean, come on. If we do all the research to buy a house, to rent an apartment, to buy a car, this is a big expense for you. You need to do your homework and you need to do it ahead of time. So let's jump into this episode, barriers to access and care. So as we all know, insurance policies can slow down the delivery of care. There are delays and denials that can occur, especially if a prior authorization is required, and we'll talk about that. Insurance comes with complexity and high out-of-pocket costs. There's a mix of access and financial protections for the insurers, but that causes access and financial challenges for us. And then often it's going to feel confusing and impersonal. Look, at the end of the day, these are giant companies. They're insuring millions of people. And so the more educated that we can be, the better. And that's what this series is about. Now, look, common ways that carriers, we're going to use a couple names, insurance companies or health insurance companies. We also call them carriers. We also call them payers. So I'll use those interchangeably. But some ways that carriers can impact your access to your healthcare services is something called utilization management tools or administrative tools. Now, these are sometimes used for insurers to control costs. Other times, they're a byproduct of administrative processes, and it can make it harder for patients to access care, access their medications, and access their services. It also creates a lot of work for hospitals and physicians and the physician staff, as well as pharmacists. And so it often draws their ire. And a number of states are passing legislation to address this issue. But we really need Congress to get involved. They need to really step up. Prior authorizations used to really be used sporadically so that people couldn't use a super expensive medication or procedure, or physicians couldn't prescribe that without the insurer making sure, okay, that makes sense. But they changed it from being a tool that made sure that things were used appropriately to slowing down care and slowing down authorization, and thus us being delayed our care for our services and products. Now, I'm going to give you a couple examples of the different barriers that you may run into or have already run into. These are not exhaustive, just some of the bigger ones. So we already mentioned prior authorization requirements. There's another one called step therapy or fail first policies, high cost sharing, non-medical switching, quantity limits and formularies, as well as delays in payment or pre-certification. So let's break down each one of those. So the first one is a prior authorization. And basically what that is that patients or providers have to get the insurer to improve certain treatments, tests, or prescriptions before they're covered. So it's usually, like I said, it's used for expensive drugs. It may be used for imaging, such as MRIs or CT CAT scans, surgeries, or specialty care. It can delay and require significant paperwork from physicians. And you talk about physician burnout. We talked with a couple of physicians in the last few episodes. The average physician practice has to complete 43 prior authorizations per physician per week. Now, that was in 2024, according to an American Medical Association survey. Physicians and staff report that they are spending around 12 hours per week completing this type of paperwork. So this is really bogging down our system. So what are your options when it comes to prior authorization? If an insurer says, nope, we're not, you need to check into this, or we're not going to approve this. Well, because they can deny, if the physician prescribes something, the insurer can deny that during the prior authorization process. But their denials, while they are common, it happens a lot, they are not final. Many prior authorization denials can successfully be appealed with the right documentation and support. And a lot of people don't know that. Whenever, I don't care if you go to a hospital, if you go to a physician's office, you go to a minute clinic, if they're saying you can't get this care, you may not be able to change that at that very moment, but there are tools and there are processes put in place by law that you have access to, and you need to know that. So typically, you have 60 to 180 days from the time you get denied to file your appeal. Now, that may depend on your insurer, but at least you have 2 months to file an appeal. So don't wait. There are clear steps that exist, and you can request from the insurer. You're allowed to do this. You can request a reason. Why did it get denied? And what medical evidence do you need? And then you can file an appeal with the insurance provider and get your physician and the office staff to help you. They will do that a lot. There are also advocacy organizations that write prior authorization appeal letters that you can go to them. So like say you're a rheumatoid arthritis patient, the rheumatology societies in your state, there's national rheumatology societies. They have advocacy organizations that will help do these type of things. So secondly, step therapy or fail first policies. This often occurs with high cost medications. So usually what you're going to see is that, physicians do this anyway, but insurers want to make sure that you are trying a lower cost drug versus an expensive one. Or maybe they have a preferred treatment. They may want you to use a generic drug or a biosimilar, as long as it is effective, before you use a more expensive option. Now, one thing is, as you know, drug manufacturers give money to insurance companies and PBMs so that their drugs can be preferred on their formularies. This is another reason why you may have to do a step therapy or fail first. Your physician writes a prescription for one drug and he says, well, your insurance company says you have to use this other medication. Talk to your doc. Make sure, is that medication going to work for me? Does it make a difference? If it's not going to work right for you, that's when you appeal. So the common drugs that are usually put behind step therapy are going to be your specialty drugs like a biologic and mental health medications. So what are your options? Like I said, you want to make sure that you're communicating with your healthcare provider and your insurance company as soon as possible. Ask your healthcare provider about the possibility of doing a prior authorization to override step therapy requirements ahead of time, So if your physician says, you know what, I want you to get this drug, but I usually get, pushback from the insurance company, maybe you and the physician can say, okay, what usually works for that to work its way out and get approved? So the physician probably has experience in that area. So maybe before he even writes your script, you submit with the physician a prior authorization ahead of time. You also want to explore exceptions to step therapy based on specific medical conditions and specific health plans. There are some medical conditions that basically are urgent, are dire, and your physician can push back and say, no, you cannot deny this care because whatever, it is an urgent situation. And then lastly, be prepared to work with your provider and explore exceptions and appeal decisions if necessary, but make sure you use the insurance company's process, because what they like to do is they like to go, well, we wanted you to provide this information and you didn't. You had to do it within this time and you didn't. So instead of getting frustrated, what you need to do is your homework and make sure that you do it the right way. Okay. So the next barrier is high cost sharing. Well, this comes in the form of high deductibles, in the form of high copays or co-insurance. And a lot of times having to pay a lot of money for some care or a drug or medical product will discourage patients from seeking care. And this happens because some plans have specialty drug tiers, so that more expensive drugs are going to cost more. So a generic drug that's inexpensive may be free or cost $5. But if there's a drug that maybe costs $20,000 a year because it's a specialty drug, it may be high on their specialty drug list. And they're going to say, well, you owe 33% co-insurance. Well, 33% of 20 grand is a lot of money. So make sure that you understand that. Now, to help with that, drug manufacturers are well aware that there are high co-insurance amounts out there for patients. So they have drug assistance copay programs. In addition to that, you have not-for-profit foundations that also can help with copay assistance. You also have some state and local programs that might be able to help with prescription drug costs for people who have lower incomes. Now, what some insurers and PBMs have done is they said, you know what, these copay assistance programs, they are not supposed to be there. The patient needs to pay as much as possible, or they'll just use expensive drugs immediately. And that is ridiculous, but that is what they say. So there's a couple terms for this. One tool they use is called copay accumulator. Another one is called a copay maximizer. Another one is called an alternate funding program. It really doesn't matter how these work. What you need to know is sometimes, even though a manufacturer or a charitable organization provides assistance to you to help for your copay, the PBM or the insurer may say, you know what, we will take that money, but when it runs out, you're on the hook. You're on the hook for your deductible. So a copay assistance could last for 3, 4, 6, 8 months. But then all of a sudden, in the second half of the year, you go to your doctor, you're like, wait a minute, I've got my specialty medication. It hasn't cost me a dime. And all of a sudden, I got a $3,000 bill. That is probably because it's one of these programs that the insurer or the PBM utilize. They absorb the copay assistance from wherever it comes. And when it runs out, they go to the patient. So that is something that if it happens to you, you need to work with your physicians. You need to appeal to the insurance company, and you need to let your local legislators know, because that is absolutely the wrong thing to do. So the other thing when it comes to high cost sharing is you have to be proactive. So one way to head all these issues off is if you're already taking expensive medications. So say you have a GI disorder. Say you are a patient who has cancer. You've been using expensive medications. Well, when you go at the end of the year, in the fall, and you're going to enroll in your benefit design or whatever insurance company, you need to do your homework. You need to look at the insurance companies or the PBM's formulary. And the formulary basically is a list of the prescription drugs that are covered by your insurance plan. But inside that formulary, you also need to understand what drugs they cover and what's the cost. What your copay or your co-insurance, what's the cost? And are there any restrictions of prior authorization, step therapy? Sometimes you can be on a drug for a couple of years. It's working great. You've tried all these other treatments. You switch health plans and all of a sudden they go, well, you know what? We don't cover that, or that's not preferred. And you need to try something else. Even it may be a drug that you've tried in the past and it didn't work and they don't care. So you need to do your homework ahead of time when you're looking to enroll, to make sure that if you're on expensive medication, that you have looked at that formulary before you sign up for that plan and you know what your costs are going to be. You also need to look at and say, okay, my physician, I've got a specialist. I want to go to them. When you enroll, make sure that they're in network. If you have a local hospital and you want to make sure that the hospital is in your insurance company, when you enroll, make sure you look at that. So a couple other things that can help you with the high cost of drugs for your copay or your co-insurance is talk to your pharmacists or your physicians. If you're getting pushback, see if there are other lower cost brand drugs that they think work just as well. Maybe there's a generic, which is basically a copycat of that drug. Or if you're on a specialty medication like a biologic, it may be a biosimilar, which is kind of a generic version of a biologic, but it's not exactly, because they're not totally identical, but quite often they work just the same. Work with your pharmacist and your physician. You can also sometimes go through mail order pharmacies. That might lower your costs. And one other thing to think about is asking your doc, hey, should I try that medication on a trial basis before I go ahead and have it prescribed and go through my insurer? So see if there is some type of a sample program or a trial program that manufacturer allows the physician to let you use. So one of the ones that I really hate, one of the barriers that insurers use, is non-medical switching. Non-medical switching is what it sounds like. When a patient is forced to change from their current medication or a medical device to something different. Often it's less expensive. Often it's related for reasons that are unrelated to your health or your clinical outcomes, even though you may be doing well on that medication. So think about it. You've been for 2 or 3 years, you've been trying different stuff, you get on a medication, you like it, you don't have side effects, it controls your symptoms, you've been on it for 6 months, a year, 2 years, all of a sudden you find out it's been denied and you need to use something else. You need to fight that. Look, insurers will often claim that they're doing it for cost savings, but study after study shows that it actually can increase healthcare costs due to an increase in doctor visits, an increase in tests, and potentially hospitalizations. And it can, as you can imagine, lead to increased health risks, treatment disruptions, and a negative impact on your overall well-being. So look, you still have options. Review your insurance plan's formulary and understand your coverage, like I said, in the enrollment period. If they change it in the middle of the year, you have a lot of rationale behind you to challenge that. You need to appeal the decision. Work with your doc to appeal that decision to your insurance company. And most states have appeal processes in place. You need to monitor, say they make you switch, you need to monitor how that new medication makes you feel and any other changes that you notice. And you need to document everything, the record of your health status and the adverse events from the switch. And then you need to let your doctor know immediately. Do not let it go for months at a time. You need to let your doctor know this isn't working. I'm having the side effect. You need to call the insurer and get it fixed. You can also explore alternative treatment options. If the switch is unavoidable and you've appealed it, you can discuss with your physician, are there other treatment options that might work for me? And then if this is going on and whether or not you get it resolved, even if you do get it resolved, let your local representatives, let your people in Congress who represent you, let them know what's going on. Let them know the impact of that horrible policy that you have been on your patient journey. You've gotten on a great medication that's working for you, finally, and now they want to switch you for their reasons, not for yours. So a couple other ones that I'm not going to get into, there are quantity limits and formularies. We've already talked about formularies. You need to know what they are before you enroll in that insurance plan. And quantity limits. Quantity limits, in many ways, I think they make a lot of sense. Look, usually patients are going to get a 30-day supply or a 1-month supply. Sometimes you can get 60 or 90 days. If it's an expensive medication, they may actually say, you know what, we're only going to do it for 15 days because what if it doesn't work? So just make sure you understand it. If your physician says or your pharmacist says, look, there's a quantity limit, ask them, is this going to impact me? And if it is, what can I do? And then there may be delays in payment or pre-certification. That's usually going to impact the physician's office, but it could ultimately impact your access to a service, a procedure, or a drug. So look, at the end of the day, there are pros and cons from a patient's perspective of private insurance. Our previous episode was basically, it walked through the basics of health insurance. This episode was not, how should I say, rainbows and unicorns. That's going to be our next episode. But this episode basically is telling you these are some of the games that the insurers play. But I hope that this helped you know some of the options that you have. But look, at the end of the day, from a patient's perspective, the pros of private insurance, as we've talked about, is you have some choices. There are PPOs, there are HMOs, EPOs. So there are different options that you have according to your situation. You have a choice of plans via the ACA marketplace if you're an individual getting or a family getting coverage outside of an employer. Preventive services are usually covered. And then lastly, one of the pros to private insurance is there's financial protection from catastrophic costs. And I think that's what we all do health insurance for, in case we have an accident or we come down with a serious illness. Now, the cons, I'm just going to limit it to 5. High and rising out-of-pocket costs. We've talked about that ad nauseum. Limited billing and coverage transparency, not just from the insurers, but also from hospitals. And Congress and our legislators are working on that. And you need to let them know that they need to work harder. Surprise out-of-network bills. Look, at the end of the day, try and stay in network. There are complex rules and administrative burdens. Your physicians' practices, your hospitals, your pharmacists have to deal with this. Just understand that. And like I said, these barriers to access and care that we just walked through. So look, we're going to wrap this up. In closing, we have to become better consumers. We have to do our research on what works best for us and not wait till the last minute. We need to work with our healthcare practitioners to navigate the medical landscape. They are here to help you. Your pharmacists, your PAs, your nurses, your nurse practitioners, your office managers and staff at your physician practices. Hospitals have navigators. Your pharmacists, both in the retail setting or in the mail order setting. And look, you can make phone calls. The insurance companies, look, we may not like the insurance companies, but the people that work for them, they're usually really good. And if you call them, they will help. And remember, if you're denied or delayed care, don't give up. Don't get frustrated. Don't get upset. You have rights and you can overcome these barriers put in front of you. You just need to do your homework. Lastly, communicate with your legislators. Let them know when insurance policies are hurting you. If you don't do that, nothing will change. So look, a lot of information, just like the previous episode. You can go to the website. We have show notes. I have slides. Everything should be in there that you need. If you have questions, you can email me through my website. I look forward to helping you. I hope this is helpful. If you found it helpful, forward it to friends. The one thing I can say, talking not just to my kids and people in their 20s, but my gosh, friends of mine in their 50s, 40s, and 60s, they're like, oh my God, please do episodes on this. It is confusing. I don't understand it. So here you got it. I look forward to getting back to y'all in my next episode, which will be the third part addressing private health insurance. And it's going to be a fun one. I'm super excited about it. Take care and talk to you soon.